Today's webinar, Moving On Up, Transitions in IBD, hosted by Crohn's and Colitis Canada, is made possible through a grant from AbbVie. Some of you may be new to webinars, so I'll quickly run through how you can ask questions and how they will be answered. Right now, all participants are automatically muted, so everyone can hear the speakers, and so we can capture the webinar recording without any audio interference. I will be presenting questions when the speakers have finished their presentation, and I will read as many questions as possible during the Q&A answer period. If you have any technical questions, you can also type it into the question and answer box or the chat box, and we will follow up with you directly. Great, we're ready to begin. Crohn's and Colitis Canada, formerly known as Crohn's and Colitis Foundation of Canada, CCC for short, was established in 1974 by a group of concerned parents of children with Crohn's disease and ulcerative colitis. We are a national charity dedicated to finding treatments and cures for Crohn's disease and ulcerative colitis, and to educating people with these diseases and the public. We want the general public to be aware of these chronic diseases and the toll it takes on nearly 250,000 Canadians living with Crohn's and colitis. We also want people living with these diseases to be well-resourced as possible. Crohn's and Colitis Canada has funded over $88 million in research to date. That makes us one of the largest funders of Crohn's and colitis research in the world. We have more than 65,000 supporters, many of whom are actively involved in our 80 volunteer groups and chapters across Canada. Today's webinar is part of Crohn's and Colitis Youth Engagement and Education Programs, which includes the AbbVie IBD Scholarship, Camp Got to Go, for children and teens living with Crohn's and colitis, and this, our first ever youth-focused webinar series. Our education materials cover a variety of medical, social, and psychological issues related to Crohn's and colitis. We have brochures covering issues specific to children with Crohn's and colitis, ostomy care, medication, and many other topics. If you would like more information about Crohn's and Colitis Canada, please visit our website at crohnsandcolitis.ca. I'm pleased to introduce to you our first guest speaker, Karen Frost. Karen Frost is a nurse practitioner at the Hospital of Sick Children's Inflammatory Bowel Disease Center. She earned her master's degree in nursing at the University of Toronto in 2007 and is now an adjunct lecturer at the Lawrence Bloomberg Faculty of Nursing of U of T. Karen is the IBD Educational Resource Lead for the Sick Kids IBD Center, has published many educational materials for healthcare providers and patients, and she is the lead project manager of the My IBD mobile app. In 2008, Karen saw firsthand the importance of transitional care and started a multidisciplinary IBD transition clinic, which at present is in solid collaboration with Mount Sinai Hospital in Toronto. Karen has received multiple nursing awards, including the St. George's Society of Toronto Florence Nightingale Award in 2006 and the prestigious Grace Evelyn Simpson Reeves Award in 2011. Karen, take it away.
Thank you so much, Faye. I hope I didn't put anybody to sleep with that bio. So thank you for having me. This is Karen Frost. I always compare to transitioning pediatric to adult IBD as like the Big Bang Theory. 13.7 billion years ago, what we had thought we believed was that universe collide. And this is sort of how I feel as well with transitioning patients. in that they need to move from pediatric as a young adolescent to the adult patient population in a bigger hospital with big IBD doctors. So having said that, Faye, do I have control of the slides? So the one thing I'd like to always ask myself is, why do we highlight pediatric to adult transfers? I'll tell you why we do that, and that is because, next slide. If you look at this particular colonoscopy photo, it's really no different than that of the adult photo. This particular colonoscopy photo is that of a young teenager. So your parents have probably seen the photo and bought the video. Similarly, with the adult, if you look at it closely, there's not a lot of difference really. So again, when we look at the principles of therapy between teens and adults, there's not a huge amount of difference in that the goals are very much the same. For example, we all aim to decrease inflammation and get rid of symptoms. We all want to improve and maintain quality of life and avoid long-term complications. But also, in pediatrics or the young teenagers, we also have to worry about growing up into big grown-up people. And not only that, there's also that race for time in that we try to accomplish so much, applying for university, asking a girl or a boy out to the prom and what have you. And there's so many things that we want to accomplish, including getting a part-time job on top of having to deal with inflammatory bowel disease. So I think in a nutshell, people or the patients who are in that young age group really have a lot of pressures on them, and the reasons for this seminar is really to provide you with the tools that can help you transition better. Not only that, really the things that are happening to a teen's body is also quite scary to some as they feel that they're losing more and more control. This is a popular book that addresses really what's happening when puberty kicks in. Now, that maybe changes the game a little bit, although the principles of therapy are the same. As young adolescents, now we have to worry about you guys optimizing your growth, normalizing your pubertal development, and really encouraging that social development that you may have. So the question is, why should your doctors and nurses care? I'll tell you why the reason is. In the last 2 decades, we have actually seen an influx of the peak incidence of IBD in the younger age group, that of the 15 to 25-year-old patients. And this is something new. We have never seen that before. And the ages do get younger and younger each time. So when we look at treatment strategies between adults and pediatrics, they're really not at all the same. In adults, they want to achieve remission. That means to make them feel better. And the same thing with you guys, as young teenagers or young adolescents, the goal is very similar, and that is to make you feel better and to keep you at that mode where you still feel better for a long time. Traditionally, when we get a young patient into remission and we want to keep you there, the standard treatment is use of steroids, or what some of you may know as prednisone or prednisolone. It is classic, and yes, it does get patients into remission, but is it really good for long-term maintenance care? Not at all. The reason being, we see a lot of side effects that your providers probably had told you about when you go for your visits, in that it gives you what they call the moon face or the chipmunk face, the weight gain, your bone health is compromised, you have your mood swings, you have hypertension, and really more importantly, there's that issue of delayed puberty and growth failure that we want to address. So if we had the luxury of avoiding steroids, what other treatments in pediatrics do we entertain? We entertain the use of exclusive enteral nutrition. Some of you may have heard this, or some of you may have heard or know of people who put in what's called a nasogastric tube down their nostril either every night or part of the day to feed themselves formula. I'm not talking about baby's formula, but formula specifically for patients with IBD to get all their nutritional and caloric requirements. The typical proposal for what we call EEN, or exclusive enteral nutrition, is a 6 weeks of exclusive liquid diet. So apart from the formula that you take by nasogastric tube or by mouth, we also have a small list of clear fluids that you may have. And if patients do want something solid to chew on, we do allow for some gummy bears. Does it work? It absolutely does. And when we actually present this option to many patients, patients are usually turned off by the fact that it's given by nasogastric tube. However, when they actually undertake the course of treatment, they feel a lot better because they're gaining weight, they're gaining muscle mass, and they were able to avoid the use of prednisone. In fact, it's effective. It has been shown that 80% of patients do get better results as those who get prednisone, but without the side effects of prednisone. The mechanism is still unclear. We don't think it's because the formula is what's really making people better, but the fact that being on this exclusive diet, we eliminate a lot of things that's regularly in our diet that does adjust the microbiome, or what we call the interplay of the good and bad bacteria in our gut. When we look at through a colonoscopy, comparing a patient who has used prednisone or enteral nutrition, we do see that there's healing in the bowel. And on the positive note, it does promote weight gain and height gain. At least in my practice, I know that boys are always concerned when they're 14 and they look like they're 8 years old. So height gain is really an important factor when we discuss EEN with our patients. It does improve nutritional status, and when we look at inflammatory markers, you probably have heard of things like your ESR, your hemoglobin, and your CRP. We do see that these inflammatory markers are a lot improved. The next thing I want to talk about is the use of anti-TNF therapy. Some of you may be on Humira, some of you may be on Remicade. These are the two approved pediatric anti-TNF in Canada. And when we are challenged if it's really safe to be given to pediatrics, the answer is yes. In fact, in the Lancet Medical Journal in 1993, they highlight the case of a 12-year-old girl who in the past had not responded to prednisone, did not respond to Imuran or immunomodulator, but did respond to the use, in this particular case, infliximab or Remicade. To further my point, if you look at about 3 decades ago, if you look at the gray triangle, that is the chronically severe patient population that we have. When you move into the next decade after that, unfortunately, it has not changed much. As you can tell in my red circles, the chronically severe patients remain to really be the biggest chunk of our patient population. Since the advent of anti-TNF therapy, this has shifted in that the chronically severe patients are now becoming less and less in numbers, which is what we want to see. So does it work? I do feel that it does work as one of the options that we have. That is the medical and scientific part of my talk tonight. I'm now going to talk to you about really transitioning and addressing issues like sex, drugs, and rock and roll. I use that because it was a movie once and it's catchy, but really I'm going to equate rock and roll with other transitional issues. However, I will talk about sexuality first. So one of the main things that a lot of the adolescents deal with is sexuality or issues of sexuality on top of having inflammatory bowel disease. And that could really be tough in the stage that you're at. So what I always say is I always look at literature that could really help them and really find ways of what they think is impacting their ability to develop relationships. In this particular study, for example, where they look at the female gender and surgery, they had asked in a free text format response as to how these people feel about getting into a relationship. Unfortunately, almost 30% that they have a really impaired body image that really deters them from being in a relationship or meeting someone. And about 26% feel that they would need a tolerant partner to really be able to relate to them. Now, I also want to look at immunizations in your age group for boys and girls. I know that our American counterparts, the American Academy of Pediatrics, does recommend use of HPV vaccine, which you probably, some of you have gotten in your grade or in your school. And the recommendation in the States is 11 to 12 years old. And in Canada, we're really no different. HPV vaccines are safe and effective, and they are recommended for males and females ages 9 to 26. So when that letter comes in the mail or, to your teacher, and then when you give us a call or give me a call, I always say, go for it. And the one thing that I'd like to highlight to you is HPV is a non-live vaccine. So non-live vaccines are allowed for patients like you with IBD, either on Remicade, Humira, methotrexate, or Imuran to have, because these are non-live vaccines. Now let's talk a bit about puberty. We know that about 30% of children with Crohn's disease experience growth failure. and this means delays in sexual maturation. I did mention about a 14-year-old boy who was asked if he was 8, or a 16-year-old girl who was asked if she was 10. However, I need to point out that once we have established a good therapy for these IBD patients who have a delay in puberty, once we establish good treatment, they do get on a good hormonal cycle, and once they do that, they actually thrive really well accordingly to the developmental stages. So I think one of the factors that are scary for a lot of young adolescents is that they lose that control. Girls' breasts hurt, boys get erections. It's one of those things that another thing, they probably go, I have IBD, I cannot control how many times I go to the bathroom, and now I have this happening to me. So these are things that we do understand, and fortunately, I do have patients that come to me that are able to talk to me about it. Now, sexual functions, it's where you don't have to tell me, but I'm sure that a lot of teenagers do experiment just like a normal teenager, and that's the data. Sexual exploration between a patient with chronic diseases and the ones who do not have a chronic illness are equal and the same. However, the drawback with IBD patients or patients with Crohn's, for example, is that the ones with perianal fistula, it can really affect the exploration of sexuality. And the reason I bring this up is because when patients come to see us in the clinic, they feel that they're the only ones who's being punished because they have a perianal disease. But what I can really tell you is that there's a lot of patients out there and they're dealing with it in their own way. But of course, what they're feeling is that, it's targeted against them and they really are bummed out about it. And the other thing is drugs and sexuality. What are the kids reading? I had one time in one patient visit, a patient was on sulfasalazine and he was quite smart. And he says, I Googled it, Karen, and I had heard that it lowers my sperm count, and I have a new girlfriend. This is great. So what I always say, yes, sulfasalazine does lower the sperm count when you're on it, but really it should not be used as a birth control method. And I know it sounds sort of juvenile, but these are the things that I do have to say to my patients. Similarly, for girls, methotrexate is one thing that I would advise girls to be cautious about if they choose to be sexually active, to really be cautious that methotrexate is considered a teratogen. And what is that? So for people who are pro-life or pro-choosing and they do get pregnant, there's implications in the fetal development or a fetus developing if they're on methotrexate. The third medication that I'd like to point out that's not here is the use of flagyl, or it's also called metronidazole. It's an antibiotic, and it's given for people who, for example, have fistulizing disease or are post-surgery. And I just want to highlight that when teenagers, experiment with alcohol, it's important that I tell them that when they're on flagyl or metronidazole, that they really do not either stop the flagyl or metronidazole or not drink at all, because there could be their detrimental effect. So I do have patients who would come to me and say to me, it's reading week, we're all going to Mexico next week, what do I do? So these are things that you can explore with your physicians or nurses if that happens. And although I do say a lot of bad things about medication, of course, what we all wish is that for once, a medication would tell us that a medication bottle may cause extreme sexiness, but that doesn't happen, and we're not there yet. So again, I also want to touch on the gay, lesbian, bisexual, transgender population, and this particular study was done in the UK, and the reason I want to bring this out is because these are issues that are real. This does happen, whether you tell your parents or communicate with your parents or not, this does happen. So when I look into this literature, it really looks at participants of how out or how do they come out in terms of their IBD compared to how do they come out in terms of their sexuality. The results basically showed that some people tell no one about their sexual orientation, but almost everyone tells somebody about their IBD. And when someone comes out about their IBD, they almost use the exact same method to come out with their sexual identity. Now, I want to talk about drugs a little bit, and that I'm pointing to the use of cannabis or marijuana. And the reason I want to bring this up is because, again, it is a real issue. Patients do come to me about it, and I always do appreciate the fact that they're very open about it. With the use of cannabis, a lot of patients, and like teenagers lately or the young adults are very smart because they bring me a ton of paperwork that they have researched as to why this is really good. And I'll show an example later. A lot of anecdotal reports that is given to me are patients saying to me that it improves my appetite, it makes me relax, it's a bowel relaxant, but however, there's really no evidence that this is anti-inflammatory. I'd like to bring your attention to you just so you know that, there's value in what I'm saying, in that the marijuana or cannabis comes from the plant called Cannabis sativa. It probably has many, many ingredients, but the two I'm going to highlight is cannabidiol and THC. I'll go with the cannabidiol for now. So basically, cannabidiol is an ingredient that has shown to not be effective than placebo in patients with Crohn's disease. So in a study looked at 20 patients with very active disease, they had given one group with cannabidiol, cannabis basically, and the other group with placebo. And what they had found was that there's really no change in their Crohn's disease activity index, which is their CDAI. There's also no change in their inflammatory markers, and there's no general improvement in any of their blood results. Cannabidiol does not produce any psychotropic effect, and it does not seem to be effective compared to a placebo in Crohn's disease. However, note that this is a small study. The second ingredient that I'd like to show is called THC, or what's called the delta-9 tetrahydrocannabidiol, which is the second ingredient of the cannabis sativa plant. They look at the same patient population with a CDAI that is over 200, and really they gave one placebo and one with 150 milligrams of THC. So this may be reassuring to some of you, if you care, in that they do see clinical remission in about 45% of patients and clinical response up to 90% of patients. However, I'd like to put a waiver that the THC component of the cannabis sativa does have psychotropic effect. So whether it's really the cannabis or the fact that it's got a psychotropic effect that makes one feel that they're better is a different story, and maybe more research is needed. This is the one article that patients bring to me to show me that it does work, and I had to sign some kind of a form for them to access it. However, I'd like to highlight to you that really this is more probably like a blog or somebody's opinion, but really as far as proving that it helps with Crohn's disease, there's not a lot of data. If I'm bursting anyone's bubble, I do apologize. I want to talk about transition, which I equate to rock and roll really, because you are all rock and rollers, is a transition of care. One of my favorite phrases here is that transition is not a transfer. It has to be a process. Transition is a process where it gets you from point A to point B. Transfer is when your pediatric gastroenterologist simply gives your whole chart to a physician in the adult setting. That's a transfer. But what we're really hoping for is that it's a process where you, your parents, come to see us with your pediatric IBD doctor, you come to see us with the adult IBD doctor in our clinic so that we can transition you properly in a more prescriptive format. Communication is key. Talk to your parents need to talk to us. Sometimes even we kick your parents out and we only want to communicate with you. And one of the things that we recommend gastroenterologists is to really make sure that transition is an ongoing process, that family expectations are met, whether together or we see you first and they're your parents or your people that are involved in your life, and that really we give you the option of either verbally giving you instructions or in writing. We also love the fact that some people now come and says, can I see my doctor just by myself? And in the last 5 minutes, we do bring the parents in. And the parents mostly do respect that. Writing a transitional care plan is also very helpful. So for sick kids, for example, we do have a collaborative clinic with Mount Sinai where the adult doctor does come to us and we run a clinic. We actually had one today, a side-by-side clinic where we slowly introduce you to the adult team over at Mount Sinai and basically tell you what is to be expected. You have to know your own meds, tell them your disease location, and really be able to do all that. So this is probably you. You're worried about getting to know your IBD location. What really is your diagnosis? You have joint pain, which is what we call extraintestinal manifestation. Some people have joint pain, some people have skin problems, some people have vision problems. You also worry about the need to adhere to all your medication. You worry about potential surgery, risk, blood test results, needing to get to the lab to get blood tests even. So we all know that. But I want to assure you, my young Padawan, you youngins, is that you already know a lot more than you think. And I know this. In fact, I do believe that sometimes my teenage patients know a lot more than that of the adult patient. For example, in the adults, if you talk to them about enteral nutrition, they have no idea what you're saying, but you can tell them about it if you've been already on it. Very frequently, you have also tried immunomodulators, or what we call Imuran or methotrexate, or you know about anti-TNF therapy, which is Humira and Remicade. And likely, you're probably also on some kind of a combination therapy, either with methotrexate plus Remicade, or sulfasalazine plus an enema or a probiotic plus Pentasa, whatever that you're on. Likely, you know all your meds because you have been taking it for a few years. The bottom line is, believe you me when I say that you know a lot more, and I know that with my teenage patients. So what is the difference between pediatric and adult healthcare system? In pediatric, it's multidisciplinary. You have your dietitian, you have your social worker, you have your nurse or nurse practitioner, you have your physician. It's very family-centered. I see people bringing Nona, their neighbor's aunt with them because there's their family support. It's very protective. A lot of parents hold your hands in your visits. However, in an adult setting, it's often a single doctor that's seeing you, and there's nothing wrong with that. It's more of a collaborative approach. It's a decision-making between the two of you. It's very patient-focused. It's just on you, not what your mother thinks you should be eating, not what your dad is saying that you should be exercising, and really the expectation is that you are more independent. Hence, the term transition. Now, what about you? Yes, you. What is your role? You depend on your mom. You look up mom, Dr. So-and-so asked me what my meds are. What is that name again? And that's okay. You have that passive role in decision-making. It's a slightly immature for now, and your appointments are usually managed by mom. You probably can't help that because you're probably your driver until you get your license, right? But with adults, it's a bit different. You're independent. You either attend alone or with a partner. You make an active role in your decision-making, and you are able to communicate or dialogue about risk of treatment. And you're really responsible for assessing your own symptoms, reporting your own symptoms, and organizing your appointments with your physician, or even bringing yourself to the ER. However, we know that's not the only issue. Back to evolving, right? So you need to evolve as a human being from a child to a young adult. And really, we know that there are milestones that you have happily achieved. Your parents clap when you start to roll and walk and talk and skip. Even when you mouth off to them, they're like, oh, they're a normal teenager, that's fine. To the time that you leave home. However, there's also that gap that we need to acknowledge. Again, going back to what's happening to you, the changes in your body. How can we do that? So really, what is your to-do list as an adolescent? You want to achieve independence from your parents. You want to adopt a peer code that is yours. It suits your lifestyle. You want to wear your hair that same way? Fine. You want to wear your pants low? Fine. You want to take your meds? Great. You don't want to take your meds? Not good. We're going to be on you. And of course, establishing sexual and ego and really what you want to do in your post-secondary education, applying for university, going to college, going to an academy, and really developing a moral code, what's wrong and what's right. And I know that while you're trying to get all of these done, you're also trying to be independent, you're trying to achieve an active role in your decision-making, and really looking after yourself. And not only that, we then expect you to get used to the adult setting where it's often a single doctor, it's very focused on you, and really you're expected to be quite independent in your care. So why does it matter? It does matter because moving on up successfully is really has been associated with long-term disease management. So when you move on up successfully, you better adhere to your medications, you have better adherence, and that you have a better improvement in your quality of life, and that has been studied. So how do you do it? This is the position statement from NASPGHAN. So NASPGHAN is the North American Association of GI people that knows about IBD. And what they say is they want to promote self-reliance, meaning you relying on yourself for that behavior independently that could really impact your care as you move along the transitional continuum. So again, my hope is that you go from relying on your healthcare provider, who really is your best resource, you look up to whatever they're saying, to relying on your parents, who manages your disease, your meds, they put in the pill pocket, and really to you, that in time you become the supervisor or the chief executive officer of your own disease, and that's what we want to see. Some resources that may help you is a Good to Go program timeline. It goes from birth to 18 years old, birth because we now are seeing more and more younger people getting inflammatory bowel disease, but by the time that you switch to the darker orange to the lighter orange color is that you are more independent, meaning You know your pharmacy phone number. You know that when you're 21 and your parents' insurance can cover you, do you have university insurance plan that can help you? What bathroom can you ask from university? Can you ask for a semi-private or a private? Can you ask for a fridge? And Carly may dwell into more of that, so I'll leave that for her to speak about. A variety of tools that we have is a Good to Go transition program. It's available for free at the Hospital for Sick Kids website, and it's really to prepare you to learn more about your disease. At the very end of this, you're able to print what we call a passport that looks like this one. So basically, you write your name, you write when your last colonoscopy was, and when your last medication was. Why do I encourage you to do this? Some of you may choose to backpack to Europe. I don't expect you to bring your 5 volumes of hospital chart or a copy of it. I don't expect you to bring a red binder that your parents help you prepare. But really, you can bring a My Health passport. It's the size of a license when you print them, laminate them, okay? And this becomes the chart that you transport with you so that if something happens to you, okay, you're able to go to an ER, say, in France, hopefully near the Eiffel Tower, and bring this to you, and then they can visualize what medications that you're on so that when they treat you, they know what to give you and what not to give you. Another thing is that there are a lot of mobile apps out there. The one that I'm going to highlight is the one that Sick Kids has produced. It's called My IBD. You can track your stool, your abdominal pain. You can have the access. You can access the IBD Academy, which is right here. That's got a lot of resource in PDF format or video. And also, there's this My IBD passport. If you don't want to carry a laminated, license-sized My Health passport, go digital. It's right here, okay, at your disposal. The other resources that we have developed is really a certificate. It's cheesy, but any type of certificate is nice when we give it to graduating patients. This is the Good to Go timeline that I had talked to you about. There is the My Health passport that I have talked to you about, and the 3-sentence summary. Name me 3 things about you that you can tell about your disease. And why is that important? When you go to the ER, when you go to an adult setting, they want to know what you have. You have Crohn's disease. Where's your Crohn's? It's in my large bowel. What meds are you on? So pick your 3 key sentences that you want to repeat to your adult doctors when you see them. This is also a resource that we have, sort of a checklist of what we want you to do. And we also have, in our hospital at least, we have a So You Can Interview session where we help you get a job or find resources to help you a job. Just in the last 2 minutes of my talk, I want to bring your attention to this readiness checklist. It's accessible through the Sick Kids website. It basically is a checklist for parents and patients. Patients are asked, do you know what your pharmacy phone number is? Do you know where your nearest walk-in clinic is? Do you know your nurse's phone number, your GI clinic's address? And it asks the same questions to your parents as well. It's quite helpful because it just gives you prompts of what you need to know. So basically, ladies and gentlemen, in summary, adult and pediatric therapy goals are mostly the same. And the only difference is that are things that pertains to normalizing your growth. But once you are on a good therapy and you hit puberty, you should be able to develop similarly in your pubertal stages as those others with no inflammatory bowel disease. And again, in young adolescents with chronic conditions have similar sexuality patterns as those without, with the exception again of needing to address delay in puberty. And lastly, transition is the process that is most effective when you, as a patient, is central to the process. Okay? So what is IBD? And I always want to promote normalcy. This is IBD. This is a hockey tournament that was funded by AbbVie and Robbie's Rainbow alongside Sick Kids. And really, you have IBD. It's what you have. It does not define you. So I leave you with, take pride in how far you have become and have faith in how far you can go. Thank you.
Thank you, Karen, for that excellent and very informative presentation. I just want to remind participants or attendees this evening that you're welcome to ask any questions you may have in the question box on the right-hand side or left-hand side of your screen in the webinar toolbar area. So please share any questions you may have for Karen or our next presenter, and that would be wonderful. So I would like to now present to you our second speaker. Our second speaker is Carly Lindsay. She will be sharing with you her personal experience of living with ulcerative colitis and how she successfully transitioned from high school to university. Carly Lindsay is originally from Waterford, Ontario. She's a fourth-year nursing student at Queen's University. Upon graduation, Carly plans on pursuing further studies in gastrointestinal and ostomal nursing. At the age of 9, Carly was diagnosed with a very severe case of ulcerative colitis, and 6 weeks after her diagnosis, she received a permanent ileostomy. Since then, Carly has trekked to the base camp of Mount Everest to raise awareness for IBD and those living with ostomies. Carly is a member of Gut Inspired and is the chair of Queen's Invisibilities, and in 2007, Carly was awarded the AbbVie IBD Scholarship. Take it away, Carly.
Thanks. I really wish that I had Karen to speak to me before I transitioned, because that was great. So thank you, Karen. But as I was just introduced by Faye, my name is Carly Lindsay. I'm a fourth-year nursing student up at Queen's University, which is in Kingston. Next. So this is kind of where my IBD story begins. I was diagnosed at the age of 9 when, literally right out of the blue, I was hit with a very severe case of ulcerative colitis. There was about maybe 2 weeks in between the onset of symptoms and hospitalization, which led to my diagnosis. So it was kind of a big whirlwind. And my intestine was so inflamed and ulcerated that I needed a blood transfusion every week of my 6-week stay at McMaster Hospital. Next. And for me, the medicine wasn't really cutting it. I was on a lot of steroids, as you can see in the next picture. And I just popped right up. I had those great chipmunk cheeks. But other than that, it really wasn't getting my disease under control. So in the end, I opted to have ostomy surgery and have my entire large intestine removed. Next. So some of you here may have been confronted with this option at some point, or it might be something down the road. But for those of you who don't know what an ileostomy is, my plumbing doesn't quite work like everyone else's. My waste goes into a plastic pouch, which is attached to the outside of my stomach area. And for me, this operation quite literally saved my life, as I was discharged from the hospital about a week later, and it was one of the greatest moments of my life. I was so happy. Next. So after my initial hospital stay, I had a bit of a learning curve. I spent a couple overnight stays after that for things like dehydration, kidney stones, food blockages, but they weren't really serious. Overall, my quality of life was a million times better. So I was quickly back to a regular kid. I resumed my ballet lessons. I took swimming lessons about 6 weeks after surgery. My mom thought I was crazy. But I proved her wrong. And then eventually in high school, I kept doing ballet. I joined the cheerleading team. I had a part-time job, and I felt like my second part-time job was filling out scholarships, which eventually paid off with the AbbVie scholarship in 2012. Next. And then in grade 11, my life kind of completely changed. I was invited to trek to the base camp of Mount Everest with the Intestinal Disease Education and Awareness Society to raise awareness for those living with IBD and ostomies, and to really show people that IBD doesn't stop me. I also started publicly speaking about my illness and came out of the bathroom, so to speak. So up until this point, I had been pretty private. Some of my close friends knew, but that was about it. Next. So as part of my coming out of the bathroom campaign, as I like to call it, I spoke to over 30 local community groups, including Crohn's and Colitis chapter meetings, symposiums. I made a deputation to our local county council, and the one in the picture here is actually talking to over 500 of my fellow classmates at a school assembly, which was absolutely terrifying. Next. The trek itself was about 22 days, and it was the hardest thing I have ever done, both physically, emotionally, and mentally. Next. And although the trek was extremely difficult, I proved something to myself that was greater than anything else, that I could really reach any goal that was put in front of me with or without the challenges of having an ostomy and IBD. Next. So then it was grade 12, and not only did I graduate from high school, but I also graduated from pediatrics. Next. So I was a patient at McMaster Hospital, and when I was transitioning, they were kind of implementing the beginnings of their transition program. So I was kind of like the pilot study. So I had one pediatric appointment when I was about 17, and then about six months later, I had one with my adult GI, and then I would have a final pediatric appointment about 6 months after that, and then I was off in the adult world. And as I had not been sick since I was 10 and basically had my surgery, when I was considering university choices, I didn't even think to factor in proximity to my hospital or my proximity to a family doctor or a GI, just because I had been so well. But obviously, if I was a little bit sicker or needed my doctor closer, that would have definitely affected my choice. So next. So then I was off at my first year in Queens. And before you even arrive on campus or even apply to residence, which I think the deadlines are in May or June, contact Disability Services because they will be your best friend. So in first year, I lived in residence. There's a picture on my floor on the lower left. And through Disability Services and a note from my doctor, I was able to request a single room with my own private bathroom. So that was great. I found out my residence assignment and wasn't in the res that I thought I was going to be in and called them really upset and found out that I had a private bathroom, and I was so excited. Also, through Disability Services, they offer things like exam accommodations. So right now, I'm allowed to take unlimited amount of bathroom breaks during an exam. I also get extra time if I'm needed. So if I need it, sorry. So if I need, say I spend like 15 minutes in the bathroom during an exam, I can kind of add that time onto the end of my exam so I'm not rushing at the end. And then they also offer things like having a note taker. So if you know that you're going to be missing class a lot or those kind of things, you can have someone that will take notes for you. They can also help with extending deadlines if you end up getting sick. And they offer things such as counseling, peer support. The list really kind of goes on and on. And then on to professors. I know you probably all think that they're really, really scary, but they're not. They're definitely real people too, and they're very understanding of extenuating circumstances and illness if you tell them in advance. Obviously, they're not going to be pleased if you email them a couple nights before a deadline or a midterm, and you're like, hey, I'm having a flare, like haven't been able to do this paper. They're not going to be that understanding. So my advice would be to send them a heads-up email at the beginning of the semester, just saying like, hi, my name is Carly. I have these accommodations through Disability Services, and there is the possibility that I could get sick this year and will need extensions. And they're very, very accommodating in the experiences that I've had. I had one prof that actually had Crohn, which was kind of cool, so he knew kind of exactly what I could be going through if I were to get sick. And obviously putting those tools in place before you actually need them is crucial. And then one of the other strategies that I really took advantage of was lightening up my course load. So a lot of faculties offer a ton of flexibility in the schedules. So if you need to take, say, even 5 years to graduate from your university program, that's 100% okay. In nursing, unfortunately, it's fairly rigid. So to lighten up my schedule personally, I took a lot of summer courses to get my electives out of the way, which made a huge difference during the year, as just one course can take up to like 12 to 20 hours a week. which doesn't seem like a lot, I guess, in comparison to high school classes, but it's also a lot of extra stress that is added through those courses. Next. And on campus, there are also a lot of student support that you can utilize. So, for example, at Queens, we have over 200 student-run clubs on campus. And we have a Crohn's and Colitis chapter, we have Invisibilities, Peer Support Center, and basically anything else you can imagine. So they're not just health-related. We have like a comic book club, we have engineering groups, we have commerce groups. Basically anything you could imagine we have on campus. So if you just want like a social outlet, it's definitely there. So personally in second year, I got involved with Invisibilities, which is a club to promote awareness and education about invisible chronic illnesses. So right now I'm the chair. So I help organize events such as the Buddy program. So we match people up, we run yoga classes, we have guest speakers, we host events and socials, and we also have pet therapy. So we bring in a therapy dog. And another important support system is your social support. So keeping in touch with your family either through visits, phone calls, Skype, kind of any way that you keep in contact with them, as well as making friends that can kind of lead you on and lift you up when you need it. And of course, if you're moving to Newtown, there's also a lot of other resources within the community that you can utilize. Next slide. And then it came to third year, and my colitis flared. So it was the first flare in like 11 years, and it was just a combination of a high-stress clinical rotation, poor nutrition, lack of sleep, basically just a really lot of stress that led to the 6 inches of large intestine that I still have to flare up. So I was completely caught off guard and unprepared. And it literally kind of kicked my butt. And the ulcers came back, so I was bleeding a lot. The arthritis and joint pain in my knees started acting up again, and the fatigue literally hit me like a wall, especially when trying to balance the demands of school with 12-hour shifts in the hospital. There were Fridays that I would come home from class at noon. I would take like a 6-hour nap, and my housemates would come in and like check my pulse to see if I was still alive. And I would wake up, eat a little bit of dinner, and literally just sleep through the night and sleep in until like 11 or 12 the next day. So it was a big change for me. Also at this time, I was a good 4 hours away from my GI, meaning that I would have to skip 2 days of classes to go see him, which really wasn't going to work with the demands of my program. And it was also a 2-month wait to get in, which I was not really expecting in pediatrics if I needed to get in. It was a lot shorter of a wait time. And within Kingston, I don't have a family doctor. So actually going through the process of getting a family doctor and then getting recommended to a GI was going to be about the same time as just waiting to go home to see my GI. So thankfully, I got to go home on Christmas break and see my GI. So I was put on medication, which did end up getting my flare under control and put me back into remission, which was great. But I also had to make a lot more kind of lifestyle changes. So things like stress management, exercising, and eating healthier were big to-dos on my list. Next. So if I could go back, I would definitely ask my GI for a referral to a GI in Kingston, just in case something were to happen or I needed anything. It's really all about being prepared and having the resources in place if things go worse, and then being able to advocate for yourself if they do. So currently, I am still in remission. I go to weekly yoga classes. I'm attempting to eat healthy, as well as I'm volunteering with Gut Inspired. I'm the chair for the Queens Invisibilities chapter. Keeping up with a full course load so far. I have 2 essays due next week, and I'm kind of panicking. But it's been busy, but it's been really manageable and really rewarding. So I really hope that my experience has helped ease your transition in some way and helping you avoid some of the hiccups and bumps on the road ahead. Living with IBD can be challenging at times, just as going off and pursuing post-secondary education is. But overcoming those challenges is what makes us strong and resilient and able to overcome anything that the world or our bowels can throw at us. So thank you.
Thank you, Carly. Thanks for sharing that very inspirational story. I enjoyed listening to it, and I'm sure our participants really enjoyed listening to it as well. Now, before we get to the question and answer period, I wanted to remind everyone about November, Crohn's and Colitis Awareness Month, and the next webinar. Our final youth webinar will take place on Wednesday, October 29th, titled Healthy Living for Healthy Grades. Our expert speakers will have tips to ensure you have an A+ experience at school, including strategies to staying healthy. You can visit crohnsandcolitis.ca/webinar for more details and to register for this webinar. November is Crohn's and Colitis Awareness Month in Canada. Did you know that 1 in 150 Canadians have Crohn's disease or colitis? Visit crohnsandcolitis.ca for November event listings. And please follow us on Twitter at GetGutsyCanada and on Facebook at Crohn's and Colitis Canada so you can share your story and see other stories too. Now on to our question and answer period. I have a question here. There's an individual asking, should I inform my employer of my UC? If so, what kinds of details should I be giving out? That question could be answered by Karen or Carly.
This is Karen. So what I normally tell my patients, patients ask me, do I have to tell my teacher? So similarly, do you have to tell your employer? I would say that if it is impacting your work life in that you need accommodations or special accommodations to have easy access to the bathroom or be able to take more frequent breaks, I would tell your employer. On the other hand, if you are afraid of the stigma attached to UC, what I always suggest is really having a talk with your employer about your disease just to foster more understanding. So if you feel that it's going to make your life easy at work by having accommodations, I would go ahead and tell them.
Okay, thank you, Karen. The next question I have here, Carly might be able to answer this one best. Where can I find information on various scholarships available for someone with UC?
The big one, I would say, would be the AbbVie IBD scholarship. That's like the big main one. A lot of the other ones that I applied for weren't UC or Crohn specific. I applied for a lot of local ones as well as nursing ones, just because I am in nursing. But I would say the main one that I've applied for with the UC would be the AbbVie one.
Okay. Another question I have here via email is, do you have any tips for coming out in regards to your disease to new students that you've met in college or university? So you've met somebody for the first time. Any icebreakers or tips or suggestions you have?
I think just to generally be positive about it. For me personally, since I am very open about it, you could probably look at my Facebook profile and guess, like instantly, that I have either an ostomy or that I have like bowel issues. But just like it came up on a first date once, and just being positive about it and being able to explain it and explain how you're kind of dealing with it and that it's not controlling your life. If that kind of makes sense.
No, that's great. For Karen, now if students are transitioning from high school to university and they're traveling to different universities in different provinces, what sort of tips or strategies do you have in order for a student to keep in track with their treatments? Any recommendations?
Yeah, that's actually a very great question. And many times in the past, when I have a student going to Dalhousie, for example, I would always connect them to an adult IBD specialist over in Halifax. So that's one thing that I want. So I always give them two things that they need to carry with them. One is that you have a contact person of an adult capacity to look after your Crohn's or ulcerative colitis when you're a different province or a different town. And Carly had alluded to that she wished she had found a Kingston physician to look after her. And I think that's one of the key components, because when you're in a flare, the flare sometimes does not wait for you to find a doctor. That's one. Focusing on the second aspect of things, if you want more tools that are more independent, that you have more control of, again, bring a digital chart, be it the MyIBD passport that you print or through an app. Have all that information on your person, on your body, to take with you for when you're in university, so that when you go to a walk-in clinic and you have the flu and they're trying to push, just for example, an ibuprofen or Advil flu cocktail, you can say, you know what, here's my medication, here's the list on my digital passport, am I okay to have that? And the reason I bring that as an example, for example, in ulcerative colitis, Advil is usually not something, it's something that we contraindicate. It causes GI bleed. So again, have resources in your destination, that being an IBD adult specialist, and B, carry your own chart, empower yourself, and really own your disease to say, this is my chart, this is what I have, please peruse through it and see what contraindications I may have before you prescribe me anything.
Thank you, Karen. Now, just to expand on that question as well, can treatment options vary in different provinces? For example, is there something that somebody who has been diagnosed may not be able to receive in one province, but will be able to in a different province?
I can answer that in two ways, Faye. So, for example, generally the Canadian gastroenterology, the Canadian gastroenterologist group, they're very, very unified. So it's not a set algorithm, but they always communicate, they always meet at conferences and meetings, and although there's no formal algorithm as to how they would treat their patients, 9 out of 10, the way they would follow a treatment pyramid, be it Ontario or Manitoba, are very much the same. The only thing that I can see to be a bit different is access to specialty drugs. For example, in teaching hospitals, for example, like say St. Paul's in Vancouver or Mount Sinai in Toronto, who would have more access into research drugs for biologic therapy, for example, may not be accessed by a smaller hospital, say, for example, in Saskatoon. So those would be the only difference. But as far as standard treatment, there's almost a unified approach by all Canadian gastroenterologists.
Excellent, thank you. And we have one last question here. An attendee has asked, can Crohn's be fatal?
Do you want me to answer that?
Yes, please.
Yep. Okay. So Crohn's can be fatal if we were, say, 50 years ago. The joke that we have in many IBD programs is that we have, the joke that we have, that is that we have put surgeons out of business. Why do we say that? It's because with the advent of new therapy, okay, so newer therapy, patients being able to start on new therapy earlier on, and awareness in community pediatricians or general practitioners like your family doctors, and by awareness I mean they're able to look at the signs and symptoms of possible Crohn's or ulcerative colitis. The diagnostic process is a lot better, meaning once the symptom is reported, gone are the days where your family doctor says to you, you know what, it is just a gastrointestinal flu. You have a viral bug. Now, what they do is actually, if you say, I have rectal bleeding for the last 2 weeks, they will do the exam as to whether it is a viral flu, but likely they will also further investigate if it was inflammatory bowel disease. If they don't really know, they refer to a specialist, which is an IBD specialist. So where Crohn's were more fatal many, many years ago, it is not so much anymore. If you were to see fatal Crohn's disease, it's usually patients who have tended to not have the luxury of accessing a specialist or have not been able to adhere to treatment that's recommended for them.
Okay, excellent. Thank you very much. We're running out of time, so we're just going to wrap things up now. I'd like to take the opportunity to thank everyone who's made it out this evening, and we will be following up with you after the webinar via email to get your feedback and any suggestions you may have for future topics. I want to thank everyone for being with us today and for the great questions. I especially want to thank our speakers, Karen Frost and Carly Lindsay, for taking the time out of their busy schedule to share their knowledge with us all tonight. Also, thank you to AbbVie for supporting this webinar. A recording will be available for download on our website at crohnsandcolitis.ca. Crohn's and Colitis Canada also hosts educational symposiums across Canada every November. Be sure to visit crohnsandcolitis.ca/education to find out more. I encourage everyone to join us on Wednesday, October 29th for our final webinar on healthy living for healthy grades. Please go to crohnsandcolitis.ca/webinar for more information and to register. Again, thank you very much for joining us, and I hope we've helped answer some of your questions about living well with Crohn's and colitis. And this concludes today's webinar. Thank you and have a great night.
Thank you.
Thank you.